Welcome. Today's webinar is titled Project Period 3, Findings and Wrap-Up. Before we started, I'd like to thank everyone for being a part of this project since 2015. We know it's been a lot of hard work. I really do appreciate everyone's efforts and the commitment to this project and their patience. First off, a big welcome and reminder that today's webinar is the 8th and final webinar of the IPRO Connecticut DPH Infection Control and Hemodialysis Project. There's been a lot, but this is number 8 of 8. And as always, in order to receive credit for your facility's participation in this webinar, please survey at the end of the webinar. So watch the full webinar and then hit the link in your email to complete the survey. Jump right into the content of the presentation and get this final show on the road. So the objectives for today are to review Project Period 3's activities, some of the statewide CDC ICAR tool findings. That's the tool we've been using since actually the previous project, so Project Period 2. It's the infection control assessment and response tool that we use to evaluate kind of the status of infection control at your facility. We also analyze the Connecticut's audit results, so using the CDC audit results, you might have seen them referred to as prevention process measures. This is what they're referred to in an HSN, but it is the same tool that is being used. And we'll also evaluate the current infection control status at Connecticut facilities. So Project Period 3 began after Project Period 2's plenary in July of 2016. So Project Period 1 and Project Period 2 were really train-the-trainer focused. Really worked with one designated nurse trainer to provide them with infection prevention tools they could utilize with their staff. This project has changed gears a bit, and while we continue to work with and support the nurse trainer, the focus was really heavily ICAR focused. We did this through the ICAR assessments, the utilization of the ICAR-based training curriculum where each of you were asked to complete Module 1 and then some additional training depending on the results of your actual ICAR visit. So the other activities include the site visits to 47 facilities. These were completed as of August 2017. Again, this is the 8th and final webinar. The fall plenary that took place in Rocky Hill in September 2017, it was on the 12th and 13th. It was the same conference back-to-back just to have a little flexibility in when people could come based on schedules. But at this plenary, the focus was mainly simulation. So the nurse trainers were to participate in the simulation to, gain the skills they needed and to take the simulation back to their facilities as a training tool. While they're completing the curriculum, while they're retraining staff, new staff, whatever it may be, simulation has been shown to be more sustainable and improve practice. So that's kind of why we switched focuses to really be heavily simulation versus presentation focused at that plenary. And then the 10 follow-up site visits. So these were completed recently in December of 2017, and we'll get into those a little more later. So a main portion of this project was conducting those 47 site visits to all the Connecticut facilities. So again, completed in August of last year. I'm going to kind of summarize in the next few slides the findings from all 47 facilities. See them in graphs that were generated by DPH based on the CDC deliverables. So after I complete an ICAR, we submit them to CDC, but the facility identifiers are removed. So the facility identifiers are on that original ICAR for, my use to be able to report back to you and, evaluate actually at the facility level. But when it gets submitted to CDC, they don't want to see the broad picture of what's happening at the state level. So facility identifiers are removed. I know that was a big piece of mind for many of you when it was out in the field when you knew it was in the CDC. So luckily, there were minimal gaps in the actual ICAR domains, as most of the dialysis corporations do have the appropriate PMP in place. So any gaps that were really related to the PMP were identified implementation rather than the existence of PMP. So for example, some facilities have a PMP stating to clean their med prep area prior to any medication preparation. So they have the PMP in place that meets one of the ICAR questions in domain 11, but have actually been cleaned their med prep area prior to each preparation. So therefore, yes, they get a yes in that domain. But again, this was an implementation. This was a practice issue versus a PMP issue. So that being said, the majority of the gaps identified were in practice. So using the CDC tools, I used 7 of the 8 of them at my site visits. The ICAR tool does not include decannulation, so I used all of the other decannulation. So again, these audit tools, you might have heard them referred to as prevention process measures or PPM and HSN, but it is the same CDC audit tools that can be used on the CDC dialysis safety website. So these tools do correspond, but are not directly related to an ICAR domain. So, for example, the dialysis station routine disinfection tool corresponds to domain 7 environmental cleaning, while it's not, directly in that domain. All right, so a quick overview of the gaps. If you remember the ICAR, the domains are composed of yes or no questions. A no response indicates room for improvement or an infection control gap. Yes answer, that requirement has been met. So the yes answers in these graphs are identified in green, and the no responses are identified in red. Each of the bars for each question, the red and green, the column will total 100%, so to account for all 47 facilities. So domain 1, looking at the graph we currently have on the screen, this is infection control program and infrastructure. So this first column, I'm not sure if you can see my mouse on the screen, but this first column here with the large deficiency is related to the CDC Prevention Collaborative that the majority of facilities in Connecticut are not participating in. So this is a nationwide collaborative to identify risks of infection and work together to really reduce those risks. That's where the 9 interventions were established. It's been ongoing since 2015. Don't quote me on that, but there were the 9 core established. So states work together, facilities work together to identify infections and modalities that kind of reduce those infections. So while most facilities are not currently participating, they can too, and it's pretty easy. Really are encouraging people to do this. So participate, you just need to go to the CDC Dialysis Coalition link, which can be found right on the dialysis safety website. Pretty straightforward. It's kind of with all the other CDC resources. So the other column I kind of want to highlight is, let me see, the posted. So this middle column here, let me go back up. So the middle column here, we want to see signs posted for patients to speak up. So you can see that in this column, then green. A lot of facilities on self-evaluation are checking yes, they have these signs because they have cover your cough, or they have the network grievances posters that says speak up, but that's not related to infection control, and cover your cough is more related to interventions that should be taken, if you come in symptomatic versus speaking up to caregivers. So what this sign is looking for is, the patients feeling empowered, encouraged, educated, know when there's breaches in infection control, and then speak up. So for example, they should feel comfortable speaking up if they see a staff member not washing their hands, or if they feel their site wasn't disinfected appropriately prior to cannulation. Mask is being worn inappropriately, such as below the nose during catheter care, things of that nature. So we want to see patients being encouraged to speak no matter who it is, whether it's another patient, whether it's a nurse, whether it's a tech, whether it's the medical director, whether it's a nutritionist, an APRN, a social worker. Everybody in the facility, we want to be practicing the same infection control standards, and we want to see patients speaking up to encourage that behavior and to protect themselves. We all get busy when we're working and things happen. So should feel comfortable, like, hey, I didn't see you wash your hands, and, going to access their site or whatever it may be. So while the gap isn't huge, it's not mostly red like a few of these other columns, there is improvement. And personally, from my experience going out into the field and seeing this, it is important. So in the final column, I'll just talk about quick. This is really nothing that can really change at the facilities. This is just a lack of the waste handling option ports that a lot of your machines aren't equipped with. So this is really a gap versus the machines per se, and there has been infections shown to be related to those waste handling option ports. So as long as you're disposing of your waste appropriately and disinfecting appropriately, there should be no issues. So domain 2 of the ICAR tool, this is infection control training, competency, and audits. As you can see, it's almost all green, which is mostly all yes answers, which is great. The very few red columns are related to in training and routine auditing. So just as a general reminder, and again, most people are doing it, but all staff should be trained on key infection prevention topics upon hire and annually. In addition, we want to see routine auditings being taken place all staff on all key infection practices. All right, so again, mostly green. This is domain 3, healthcare personnel safety. Really great job on all of this. The only red that you'll see right here is related to work exclusion policies to encourage reporting of illnesses without loss of wages. So basically what this is saying is they want to see in corporate P&P that staff is protected against punishment, loss of wages, that might come about by missing work. So we just want staff to feel safe and encouraged to speak up when they're not feeling well, they're potentially symptomatic, that they can stay home or they can go home, whatever it may be, without fear of retribution. Moving on, so domain 4, so surveillance and disease reporting. Again, overall great. We see, primarily green on this graph. The few topics where there is some room for improvement includes the sharing of your BSI should be shared with frontline staff, not just administration. A lot of places have one designated person who are reporting to NHSN who are generating those BSI rates, which is great. I mean, as long as someone in the facility is doing it, that's great. The important piece is taking that knowledge back to the staff. It's your frontline staff that's making differences and the changing in their practices. So you want to keep them in the loop. Our BSI rate was this month, was this in February versus, in January it was this much higher. So great job, keep it up, or vice versa. We've seen an increase. Can anyone explain where some improvements can be made? So that's why we really want to see the dissemination of that BSI rate. So this column here speaks to drawing of blood cultures prior to the administration of antibiotics for suspected BSI. We want CDC. We really want to see those blood cultures drawn prior to the administration to make sure we're giving them the correct antibiotic. Most facilities are doing this, and those that don't have the actual policy in place, because the question is specific to policy. So if facilities that don't have the policy in place do, in fact, do this in practice. But again, if it's not black and white, if it's not in policy, there is an opportunity for it to be missed. So, we want to see it in policy, but the important piece is in practice. So it's something to keep in mind at those facilities that if it's not in your policy, you got to be diligent about doing it in practice. Column here with some about 20% is the lack of biannual screening for hepatitis C. So most facilities are screening their patients every 6 months, and that's the CDC recommendations. But we do have a few facilities that are still screening their patients annually. We want to see the increase to every 6 months to see if there are any conversions. There was one facility that wasn't screening after admission, so again, big room for improvement there. But we encourage the screening at every 6 months. And that last red column is having a system in place to communicate any NBROs upon transfer. So anybody involved in the patient's care should be notified of infection. In this case, specifically MDROs, we want to know about VRE, C. diff, MRSA, any of those type of things, and it should be communicated to any care provider, whether they're being transferred to a short-term care facility, the the EMTs that are transferring them in the ambulance, their care providers, their doctors. There should be a system in place to communicate with all of those involved with a patient's care when an MDRO is present. And 5, respiratory hygiene, cough etiquette. I could probably say within the domains, this is probably one of the weaker domains. Still overall decent improvement, but wherever there's room for improvement, we want to highlight those areas. We really want to strive for optimal infection control. It's what's best for the patients. It's what's best for everyone. So this domain refers to respiratory hygiene measures, both in the waiting room and on the patient floor. I definitely saw some discrepancy in how people answered, because I don't think it was noted that there is a distinction in the ICAR if it's referring to the waiting room or the treatment floor. But so what CDC and we would like to see are signs and instructions for symptomatic patients upon entry to the facility on proper respiratory hygiene. So this is, like the sign cover that cough, things of that nature, which most facilities do have, but not all. So in addition to, instructions for those patients, we want to see that they have the supplies available for the patients to be compliant with those recommendations. So this means that there's means to perform all these interventions in the waiting room, such as a means to perform hygiene, just having that hand sanitizer or ABHR available, tissues and no touch receptacles are available. We don't want them to have to lift a lid. There's a lot of room for cross-contamination there. And then face masks are made available to those who need it. We also want to see the separations of patients, ideally by greater than 6 feet, as droplets have been shown to travel up to 6 feet. So this applies to symptomatic patients. So we want to see them separated from the general population by greater than 6 feet. So this, realities of what a dialysis unit looks like. And so this is sometimes really just a constraint of the facility. And I'd say even less than half of the facilities have the ability to separate someone on the treatment floor. And honestly, those that do can really only separate, maybe one patient, maybe two. But often if, it's flu season, might not have that ability if 3 or 4 other patients come in and are symptomatic. So just keep it in mind that the recommendation is greater than 6 feet, so other interventions can be put into place, wearing that face mask if necessary, pulling the patient, not maybe in front of them because you want to have, eyes on a visual on that patient as well, but other precautions taking in place, including educating that patient on respiratory hygiene, hand hygiene, disposal of tissues, et cetera. In the waiting area, we do want to kind of see the separation as well. A lot of dialysis facilities do not have someone in the waiting area to kind of monitor this, but this is kind of a patient education topic, issue, whatever you want to call it, that patients should be educated. You can even throw a step in your waiting room if you're symptomatic, please try to not sit directly next to other patients, something of that nature, but it should also just be reinforced in day-to-day education. So they know, if they're coming in, they're really not feeling good today, to not just go sit down next to another patient, to maybe, sit across the room from them. So again, that's more of a patient education area, but it is important to touch upon. So that was a long-winded domain, but we're moving on to domain 6, which is personal protective equipment, or PPE. So again, it's green, so most of the gaps were in use, rather than in the domain questions. Only gap noted in this, on the initial 47 sites were that about 25% of facilities, this last column here, not have a place for the changing or laundering of gowns in the absence of soilage. Everyone said, yes, my gown's soiled. I'm going to check. But we're still looking for regular routine changing or laundering of gowns. It's changing at all our facilities. Everyone uses disposable ones because while it might not be visibly soiled, your gowns are contaminated. You're going from station to station. You're touching, body fluids, other fluids, even if it doesn't appear so. So what we want to see is them being changed, disposed at routine intervals. In an ideal world, they'd really be changed between every patient every time you go to the station. Now, we know that's not really happening, but at the end of the day or at the end of the shift, it's fine. I saw a bigger problem where the facilities that were wearing gowns for 3 days or 7 days, and only changing those gowns when soiled. That's a problem. Your gowns are soiled. You are contaminated. The longer you wear them, the more it's exposed to, and going from patient to patient to patient. So for those facilities, there needs to be a strict protocol. Again, I would recommend at the end of that, you have to do your day. So gaps in use related to PPE that really need to be addressed with staff that I noted at these facilities include the gaps between the gown and gloves, where your skin's exposed. That's defeating the purpose of protecting yourself if you're exposed. Really, at facilities, a lot of people are rolling their sleeves up. It's hot on the floor, but unfortunately, again, that defeats the purpose of what that gown's in place for. The glove should be pulled up over the cuff of the gown. Often masks were below nose. You need to, obviously needs to be over your nose, covering your ears, and wearing a mask, especially in catheter care, but really it should be worn appropriately at all times. Appropriate PPE would be goggles and a mask over nose, face shield and a mask over nose. I saw face shields not being worn properly, worn more like a headband. So really, if there was a splash, it's going right under there. You're fully exposed. Often gowns were not tied or not fully buttoned up, so they're exposing clothes. A lot of people go under their gowns to get other items, say pens out of the scrub pockets, whatever it may be, but really that gown needs to be treated as a barrier, so no in and out. And then items worn outside of gowns, whether it's badges, supplies, whatever it may be. A lot of people have a tendency to wear badges or jewelry or hoodies. I've seen like a hood of a hoodie outside of the gown. That's the purpose. The gown is to be worn to protect everything, so they're not bringing, contaminants on your own personal items, but you're also not bringing them from station to station, so everything needs to be concealed in that gown. All right, so environmental cleaning, again, overall, great job in the actual domain. Most of the gaps identified were in practice during station disinfection. I'm going to get into much more detail on this topic a little further in the presentation, as this really was, the biggest practice room for improvement at actual visits, but also at follow-up. The CMS guidelines did help with the removal of patients prior to disinfection. There's still a lot of cross-contamination happening, so I am going to go into more detail on that. Domain 9, so we skipped Domain 8. This is in reference to dialyzer reuse, but none of the facilities in Connecticut are doing dialyzer reuse, so we're not going to do that domain. So Domain 9 is hand hygiene. Again, almost perfect yes answers within the domain, but many missed opportunities in practice, and I will go over those when we do the audit review. All right, so Domain 10, this is catheter and other vascular access care. So this is related to AVF, AVGs, and CBCs. So the biggest gap within the domain, as you can see here, the second to last column, is that over 80% of facilities reported that they're not using antimicrobial ointment on the exit site during catheter care. So this is actually one of the 9 core interventions set forth by the CDC Collaborative, where the use of antimicrobial ointment has been shown to reduce infections. So what they want to see is the use of that ointment during exit site care. A side note to that, it is acceptable to use those chlorhexidine-embedded dressings instead of the antibiotic. We would say antibiotic first, but if that's not going to work, the patches, those chlorhexidine-embedded patches, are okay to use instead. We did have an interesting question come up because there are new dressings, not just the bio patches, that do have the chlorhexidine actual dressing. And it's not a bio patch, it more is like a Tegaderm type dressing. And yeah, technically that does meet this requirement. So we would like to see more facilities switch to this. Unfortunately, that's not really being done. There's a lot of pushback. A lot of doctors don't want to sign off on this just because there has been different recommendations, different studies showing conflicting research. But at the current time, the most up-to-date research does support the use of that antimicrobial ointment. All right, so the final domain, Domain 11, injection safety. The biggest gap in this domain is much improved by now, at least at the 10 facilities I saw, and I suspect at most other facilities. So the final column here is the use of manufacturer pre-filled saline syringes, single-use vials. Prior to the July 2nd, 2017 CMS mandate that really mandated this type of use, most facilities were still drawing up flushes from the patient's IV bag and their line prior to administration. And we want it to be treated as a medication. So, prepped away from the patient, drawn up using clean technique. It's not clean technique at the patient station. So the new CMS guidelines do mandate that, but they're pre-filled syringes or single-use vials. So actual visits, most weren't, as you can see here, 94%, only 6% were. But I believe off the top of my head, all follow-ups were in fact using the single-use vials, which is great. This would be, great at it, if it was reflective now. All right, so that was it for the actual ICAR domain. If I review some other data that kind of makes it a bigger picture specific to practice or the gaps that were really noted while I was out at the visit. So, so I'm just going to kind of recap the biggest gaps that were identified using those CDC audit tools. So 47 out of the 47 facilities had gaps in hand hygiene. It was 100%, which honestly the reality is no one's probably ever going to be 100%. We'd like to see as close to that as possible. That said, while all 47 facilities room for improvement, I had some facilities that were, 90% compliant in hygiene, whereas I had some facilities in the 50 to 60% compliant in hygiene. Huge range, and that's going to be for all of these audit these practices that I talk about. That while 47 had room for improvement, some had a lot more improvement than others. So that being said, the catheter connection and disconnection, 41 out of 47 facilities, or 87%, did have and room for improvement, re-education. Catheter exit site care, 45 out of 47 facilities had room for improvement or re-education. I will talk about exit site care in a little more detail. Some of the this number and the audit results numbers look worse, so to speak, than the actual practices because of one column in the audit tool, which I will get to. So the FAVG cannulation, 46 out of 47 facilities have room for education. Med prep, 60%, so 28 out of 47 facilities. Med administration, same thing, 28 out of 47, so 60% of facilities. And then the environmental disinfection, again, 100%. And I would suspect that is still the case if I were to do a follow-up at all 47. Again, and being results, whether you're in the 90th percentile or the 50th, but there is room for improvement at every facility in environmental disinfection. So, I'm going to go with the audit tool that corresponds with the domain, kind of in order of the domain. So domain 7, the environmental cleaning domain, is the corresponding audit tool, the hemodialysis station routine disinfection observations. As I said, this is the biggest room for improvement. What I'm finding is that while most facilities, but not all, which is kind of upsetting, but most facilities are practicing a new CMS mandate that was effective as of July 2nd, 2017, that requires the patient to be absent from the dialysis station prior to any disinfection taking place. So yes, I saw one facility that was not doing this, but otherwise everyone has at least tried to do this and, have made big efforts to do this. So there was overall improvement, but there is a lot of cross-contamination, which I'm going to get into that in the next slides. Really need the environmental disinfection to almost be treated as a 3-step process. So it's the same process and setup process. So they really need to be treated as 3 separate and distinct processes. where each element of each of those processes need to be completed prior to moving on to the next. So between, if everything's not completed in the dirty process, if hand hygiene and glove change doesn't occur, you cannot move on to the clean. Same being said, clean to setup. So in the process, this is the removal of all items from the previous patient. So this includes the patient, as discussed, any of the patient belongings, any trash, any wrappers, any clamps, machine and patient clamps, prime bucket contacts, baths, tape, any supplies from the previous patient. Those dirty pillowcases, a lot of places have disposable pillowcases, all to be gone prior to moving to the clean process. So after all those supplies, the patient is gone, the machine's been stripped, everything is empty from the station, you need to remove your gloves, perform hand hygiene, put on clean gloves, and then move on to the cleaning process. Why I'm highlighting these as separate is, if some clamps are left behind or tape, or the prime bucket is often not emptied during the dirty, there's cross-contamination because they're cleaning. They're onto the clean process, and then they're removing dirty supplies with their gloves and continuing to clean. So there's cross-contamination. Their gloves are now technically contaminated, and it's no distinction in these two processes, or they're emptying the prime bucket. So the clean process is the thorough disinfection of the entire patient station, cleaning and disinfection of the machine, the chair, and any items in the station. The chair is part of the patient station. So we want to see all items disinfected. This includes those B cup holders, which unfortunately they are just so nooks and crannies. They are just a harbor for bacteria, and a lot of facilities aren't cleaning these at all. I know they're difficult to clean, but they need to be cleaned, and if they're not going to be cleaned, I'm telling facilities, get rid of them. Throw your blood pressure cup over the IV pole. It might not look as neat and tidy, but it's cleaner, which is important. So then we also need to see the remotes clean. The sharps containers that are stored in the machines need to be clean. Not the best place for them, but if that's how your facility is structured, they do need to be clean. We need to have those clipboards that are hanging on the machine, stethoscopes, the station-specific stethoscopes. The prime buckets are often not clean. All the tubing, all surfaces, back of the machine, inside the arms, everything needs to be disinfected. And they need visibly wet. So if those cloths are drying out, toss them and get new cloths. This is ensuring that the agent is in fact working, and it serves as a visual cue for the person disinfecting. When they're going quick and we see them quickly, wipe, say, the inside of the chair arm, which is often what I see, you see that Z, and you see huge areas not being cleaned. So it's a visual indicator. And it should be air dried. So the chair arms should not be closed until they're dry, and no items should be brought back into the station until it's 100% clean and dry. After your clean process is done, after you've fully disinfected everything in that station, you need to remove your gloves and perform hand hygiene before moving on to the setup, the third and final process, which is preparing the station for the next patient. So again, disinfection must be complete. For example, even if the machine is clean and dry, but you have a second staff member still working on the chair, cleaning, disinfecting that chair, you can't bring supplies back to the machine to put on top of the machine or to string the machine, whatever it may be. The whole station needs to be clean. And this needs to be completely dry. So if the machine's wet, you can't put them on top either. And don't wipe it. It needs to be air dry. So their audit is to domain 9. So this is hand hygiene. The most common gaps are related to gloving and inadvertent touches. So hand hygiene needs to be performed for donning, between glove changes, and after doffing gloves. And also, if hands become contaminated, whether inadvertently or on purpose, the hand hygiene must occur, and a glove change, obviously, if it applies. Which brings me to another point before I move on. You have those shared computer terminals for charting. Those are clean. You also need to wash your hands prior to touching and after touching that clean computer terminal. These are a huge area for cross-contamination and a huge area where hand hygiene is missed. That being said, the dialysis machine, this I shouldn't need to say this, but the dialysis machine is dirty. You can't touch that with bare hands. You need to touch it with hands. I have seen a handful of people, touch those machines with bare hands. It's not appropriate. So main 10, there are 3 audit tools that correspond with this name because it is vascular care. So we have kidneyation, AVF/AVG kidneyation, exit site care, and connection and disconnection. It looks like we are going to start with catheter connection and disconnection. The biggest gaps I've seen is the mask below the nose. This is the staff and shouldn't need to be appropriately wearing that mask. Missed hygiene before gloves or between glove changes. Procedure, so when gloves become contaminated, everything after that is contaminated if you don't change your gloves and perform hygiene. I often saw the hub not being scrubbed at every disconnect. And you open that catheter, whether it's from syringe to heparin to cap to line, that was out of order, but whenever you do it, whenever you open that line, it needs to be scrubbed before reconnecting it to anything else. Even if even if it's a syringe for, to draw back blood, you need to scrub that hub. It's placed down on dirty chucks or closing between connecting and not re-scrubbing prior to connecting. Same alcohol scrub used for multiple scrubs or both tubs at the same time. A new alcohol wipe every time. I guess what I saw for connection and disconnection. But then exit site care, again, mask below the nose. This is sad patient. The lack of glove changes and hand hygiene between the removal of the old dressing and the initiation of disinfection. This one's a big one. I didn't see it often, but the times I did, this one's a big one. That catheter dressing's been home with the patient for several days. It is very dirty. That is very much a dirty process, and you're moving on to a clean process that in a lot of other states is treated as sterile. Now, while Connecticut doesn't treat it as sterile, you are contaminating it when you go straight from dirty to clean, no hand hygiene, no glove changes. So after you take off that old dressing, you really need to perform change your gloves and then start your disinfection. Of chlorhexidine as an antiseptic. Most facilities were using it, but again, enough were using another agent. So we really want to see that chlorhexidine used as the antiseptic, unless it's contraindicated. Contraindicated, that's a different story. But as long as there's no medical reason, chlorhexidine, you should be using it. Now, the chlorhexidine swab sticks, they have a 30-second scrub time and a 30-second dry time. This was a gap I often saw, short scrubs, say 10 to 15 seconds, or no dry time and an immediate application of that dressing. Due to those scrub and dry times, in vascular care as well. And this is where the lack of antimicrobial ointment may make the numbers, well, they definitely did make the numbers look worse than they were. So most facilities are not using this antimicrobial ointment, but because it is, a core intervention established by the CDC collaborative, it is a part of these audit tools. So I have had facilities that are providing great care, following all the other steps, but this, it is an X in this column. So even if we're checking across the box here, they have an X here every single time. So it looks like they are performing at 0%. Whereas technically, yes, because there's no use of antimicrobial ointment, but in practice, they're doing everything else right. So the numbers, again, might show, 0. I tell you, they really great job other than that. So, get that antimicrobial ointment, the numbers will look better. For interventions. So one other thing, a lot of times the patients, this is a patient education thing, but if they're not wearing clothing that you can't really move from that site, which is patient education, but if they're not doing that, you need to secure that back so you're not it's not back over the site. You're not contaminating your gloves that are supposed to be clean while you're performing a clean dressing change. A lot of times they're really snug and facilities are holding them back with their gloved hands or letting go, and it's recontaminating the site, and they're not re-scrubbing the site. Their gloves are contaminated, and they're using their gloves then to, apply the dressing. That's an issue. So just keep that in mind. Always, whenever those gloves are contaminated, hand hygiene and glove change. Audit tool that corresponds to domain 10 is the ABS, ABG cannulation. Certainly, I'm not always seeing the site clean with soap and water. While we want to see the patient do it, if they're not doing it, the staff needs to do it for them. Now, primarily, we'd love to see soap and water washcloth, wash the site, wipe it off with a wet washcloth or paper towel. If that doesn't work for you, the paws or the other, like Castile soap wipes are okay, but that needs to be washed prior to disinfection. And then that's a washing process versus a disinfection, so there should be hand hygiene performed between those two. Shouldn't go straight to, if you're doing it for them, washing their site and then disinfecting, change your gloves, and hand hygiene. So then the biggest one I'd say is I've seen skin antiseptic not applied appropriately. So a short scrub time, applied in a circular motion, whatever it may be, the use of the antiseptic was not applied appropriately. You need to be following your P&P for the scrub time. You should be scrubbing and how long you should be drying it. And some of them are specific and say how many you should be using. So 4 alcohol wipes or, whatever it may be, you need to be following that. So literally just do a 1 to 2 second wipe with an alcohol pad on a site for cannulation. That site is not disinfected at all. And then if it was my family member, if it was your family member, you wouldn't want to see that site. That's how they're caring for your site. So keep in mind. So skin antiseptic not allowed to dry. That's a big step. Just make sure it's air dried with nothing touching until that cannulation takes place. Again, miss glove changes any time when they become contaminated. And then one thing I want to know on is that spray lidocaine. They're reusable. Spray lidocaine bottles are dirty. Yes, it may only be effective for that first 15 seconds. You can't spray it, not your gloves, and perform hygiene and go straight to cannulating. You're completely contaminated by touching that can. The only way really around it, because to cannulate within that time, because I understand that time constraints of spraying, having 15 seconds to wash your hands, put on gloves, it's not going to happen. Is if the patient's capable, they can spray it, or a second staff member can spray it for you. And then palpate, you should palpate before you disinfect. If you need to, palpate a difficult stick multiple times after you've already disinfected, you need to disinfect again. You've contaminated the site. You shouldn't then just immediately cannulate. And the final domain, there are 2 audit tools that correspond with injection safety. Domain 11 is the acceptable med preparation and the administration. So we're going to start with med preparation. Some of the gaps that were commonly noted were the med prep area is not clean or it's not free of clutter. So it needs to be clean, dry, hard surface. I don't want to see the chucks there. We want to see designated area free of clutter. A lot of times, while the surface might have actually been clean, then papers are thrown down, labels are thrown down. It needs to be clear of everything. Those papers are contaminated. They're coming out of the printer. They're being passed from person to person. That's not clean when they're on the site. Clutter is really a big one that's causing recontamination. Missed hand hygiene prior to preparation. Some facilities chose to use gloves for preparations. That's fine. They're not necessary as long as you are performing hand hygiene. The septum of the vial was not always disinfected every single time. Even if it's a new vial, it needs to be scrubbed before drying up. And if you're drying up, say 5 heparins for different patients, which isn't best practice, but that's kind of what is happening at dialysis facilities. When you need to drop your first heparin. You need to scrub that vial again, drop your second heparin. A lot of facilities are scrubbing initially and then drying up those 5 heparins. It needs to be scrubbed every time it is accessed. And then a huge one is why it is a huge breach. So anytime you enter a vial, it needs to be with a new needle and new syringe. So even if it's the end of a heparin bottle and you don't get your full dose, you can then enter a second vial with that same needle syringe. You combine doses, you can't a vial ever a new needle and syringe. Just keep that. So, medication administration. A big I saw, which was kind of related to catheter care, is the injection point not always being disinfected during the med administration. So it needs to be disinfected immediately prior to accessing, with your syringe to administer that medication. What I would often see is facilities that aren't practicing scrubbing at every disconnect in the catheter line is that they scrubbed upon initial disinfect, but then they back blood and they flushed, saline, and then they went to give their heparin. So having breaches in both catheter connection and disconnection, as well as injection safety. You're not scrubbing that injection port right prior to administration. A more common one is the syringes not being discarded at point of use. Those facilities that have the rolling sharps aren't always bringing it to the to right at the patient station for discard at point of use, and customers are walking across the floor to get there. If you're administering medications, bringing syringes over, bring that sharps to right outside your station. You administer it, you can turn and reach and drop it right in. Actual audit tools, but I'd like to emphasize that these tools should be used as a tool for success. They are not a means for, punishment or a ding. It's really, they should be used for learning, not a checklist. So when facilities are asked to complete them, don't just check across the boxes. That's not doing, anybody good. It's not just to meet a requirement to say you did them. It's really to learn from your mistakes so you can improve and provide better care. Excuse me. The purpose of helping the staff in the facility to improve patient care. When used successfully, the audits can identify gaps in practice, highlight areas for improvement, and guide training and educational activities. We all want what's best for the patients, so if we're not using the tools for that, we're not improving. Wasting our time by using them inappropriately. Use them effectively, provide feedback, make changes. And that's all I'll say with that. I know I've said it several times, but it is important. After conducting the ICAR and the audits at the facilities, all 47 of them, mitigation plan into place, and this was through the utilization of the training curriculum. So facilities were asked to complete 1 to 3 modules, kind of depending on the site visit findings. They were asked to re-educate their staff using the training curriculum and submit pre- and post-tests back to IPRO so we could the shift knowledge, or hopeful shift in knowledge. What we saw from our site visits, we had 1 facility that needed retraining on respiratory hygiene, facilities that needed retraining on personal protective equipment, 45 facilities that needed retraining on environmental cleaning, 3 facilities that needed retraining on hand hygiene, 15 facilities that needed retraining on catheter care, and 21 facilities that needed retraining on vascular care. So this was, again, more facilities that had gaps in these areas, but these were facilities that really needed to retrain all their staff in certain key areas. So they were asked to complete curriculum. As part of the gap mitigation plan, again, ask to complete those trainings as indicated in the previous slide, and then for data analysis, submit those pre and post tests, and then do those site visits to see if improvements are made. This is they assess for the top 2 performers to see if they were able to sustain, and 8 additional facilities to see if they were able to improve based on doing the recommended trainings, attending the webinars, and communicate their staff. We held the September plenary, which utilized simulation. We want the simulation brought back to the facility to mitigate some of those gaps that are identified at site visits, or to use whenever they see a gap or a new staff member It's a great retraining tool. And then the publication and ease of access to the training curriculum to the CTPH website, which can be found here. So moving on to our final objective is to kind of evaluate the Connecticut's current state of infection control at dialysis facilities. So through the utilization of the training curriculum, where facilities were asked to train onto up to 3 sessions, we have seen an increase in knowledge. The data we've collected has shown an improvement in scores per question from pre and post tests. So, show a considerable increase, which is great. So this is showing an increase in knowledge. The hope is that the knowledge is being put into practice. So, the training isn't, it does back to the patients. And what I've seen at the site visits, the 10 follow-ups, is that, it absolutely has. There has absolutely been an improvement, which is great. So follow-up visits were made to facilities to assess for improvements and changes in practice, and 2 facilities who were initial top performers to assess for sustainability. Overall, we saw both results we were hoping for, improvements in sustainability, and I'm going to kind of note those changes in the following slides. Facility A, this was one we were assessing for improvements. We see a huge jump in the root disinfection from 0% to approximately 60%, med administration from about 75% to 100%, med prep, again about 75 to 100%, AVF cannulation, 40% to 60%, still, good room for improvement, but it is an increase, and we're happy to see the trend going that way. I'll skip exit site care. I'm going to get back to that. Catheter and disconnection, about 75 to 100 as well. And hygiene, it looks like about 75 to about 90%. Great. The thing with catheter exit site care is you're going to see in the following, in all graphs essentially, is that, again, if they're not using the antimicrobial ointment, even if their practice improved, they went from 0% to 0% because they're not using the antimicrobial ointment. So I can say, just from observations from a non-numbers perspective, there were improvements in practice as well at those facilities I was able to really evaluate that on. So while 0% to 0% might not look like it, we all know there's results past the numbers. So facility B, also assessing for improvements. Still room for improvement in routine disinfection, but we see a 0 to 40% increase, a good increase in med administration, a sustainability of med prep around 75, so, still some room for improvement. This area, so the AVF, AV granulation, it is trending in the right direction, but still need some improvement in that area, and if it's the facility I'm thinking of, it is pretty just related to scrub and dry time. They were not really using their disinfectant agents appropriately, but other steps were good. So if they, the scrub and dry time appropriately, they will. Catheter exit site care as discussed. Small improvement on the catheter disconnection and connection. Again, room for improvements, but trending in the right direction. And hygiene, they're still just shy of 80%. We really want to see over 90%, but that's much improved from their first results, which look like they are in the 60th percent. Facility C, improvements, big improvements in the disinfection, still around 50%. We'd like to see 100. Improvements in administration, preparation, cannulation, a nice big jump. Not quite where we want it, but still a huge improvement. They about doubled in their compliance. And then improvements in connection and disconnection and hand hygiene. It looks like they're just shy of 90% on that hand hygiene. I believe they're 88 or 89 follow-up. So a little more re-education, and they'll get there. Facility D, assessing for improvements. So this facility, we can see they still need improvements in routine disinfection. We're at 30%. Better from 0, but we really need to, need to get it up to 80, 90, 100%. Sustainability, 100% on med admin and med prep. Cannulation, 80% sustained. Exit site care, same issue we're having. with the lack of antimicrobial ointment. Interconnection and disconnection, this bar makes me happy. We went from 20% to 80%. So, with a lot of BSIs being related to CVC, that's a great improvement. And hand hygiene is almost at 90%, which is great. This facility, we see improvements pretty much across the board. So this facility did use antimicrobial ointment, so we can see on exit site care, we went from about 20% to 60%. Big increase in routine disinfection. These are top 5 audit tools do show an increase. We got 0 to 60. Again, we see a huge room for improvement, but we see huge changes with what we're striving for. So you can always continue to work with them. We're not going backwards, we're going forward. So we still like these numbers. Jump in catheter connection and disconnection, and their hand hygiene. A small jump. They're shy of 90, so still a little more work to do. We're still assessing for improvements. We see big changes in the routine disinfection, the cannulation, the connection, disconnection, and hand hygiene. They're low 60s, and they're almost at 90%, which is great. I know which facility this is, and they've done a lot of hard work. I will note the med preparation, there's no data there because unfortunately at follow-up they had done all their med preparation in advance for the shift I was there for. So I wasn't able to, I'm sure there was 1 or 2 drawn up, but I didn't happen to catch them while I was watching other things. So I don't really have data to evaluate that. And then the catheter exit site care. Great. Seems there was a reduction in the amount of CVCs they have. Oh, I'm running out of time. But the amount of CVCs they have, but for purposes and data purposes, it looks like there was a decline when in fact I only saw 1 at follow-up, and they did have a gap, so it looks like 0%. I do anticipate by some of the training and education they did, if I had seen 5 to 10 more, I would have seen an improvement. So assessing for improvements here, the exit site care, the same thing happened at this facility. I was only able to see 1. So I can evaluate really the data was not reflective of it isn't true helpful data. But we see a big improvement in the disinfection, hand hygiene, huge improvement. They weren't even at 60%, and now they're, it looks like just shy of 90. Still room for improvement. Catheter connection, disconnection, we see a small decline, an improvement in other areas as well. For improvements here, big improvements on disinfection, on cannulation, small improvement on connection and hand hygiene, but overall improvements were made. And this is one of our 2 top performers, so now we're assessing for sustainability. And I, at a quick glance, definitely sustained. This is the only category where I saw a decline, and we reviewed those 3-step processes. That's where we were seeing the decline, as there was some crossing of that clean and dirty process. But otherwise, we're sustained at 100. We're sustained at 100. We're sustained at 90. We had an increase from 80 to 100. Sustained at 90. Sustained at over 90% for hand hygiene. So good job. In our final facility, again, assessing for sustainability, they have sustained all areas, improvement in med prep. The area there was any change is a tiny decrease in hand hygiene, and I believe if I remember the numbers appropriately, we're 94 to 92%. And 92% is still among the top performers statewide. So overall, really phenomenal job. All 10 facilities, they did a great job. We saw improvements across the board. So with ICAR domains, the average decrease in no answers was by about 7.2 per facility. And if you remember, again, those no answers indicate an infection control gap. So a decrease in no answers is great. It's an improvement in infection control. In practice, we saw improvements in 6 of the 7 audits. The 1 audit that we either had insufficient data because of decrease in CVC rate, which is great, or in data in the sense that there was a lot of antimicrobial ointment, so it wasn't really gauging the practice. They were going to be 0% no matter how much the practice improved. So that being said, there are results beyond numbers. The follow-up visits really did show improvements beyond ICAR and audit results, site care is a great example. So I thought why the audits didn't reflect it, there was improvements. I also saw improvements in cleanliness and patient engagement and education in practices we weren't auditing, like the use of stethoscopes, the patient scale, all those type of things. I did see improvement every single facility, which is what we want to see, which is great. Good work to everybody involved. So then we also saw that increase in knowledge with the use of the curriculum. We saw those improvements to post-test. So again, great work. I hope everyone continues to keep it up. So now what? I have about 30 seconds left. So everyone to continue to strive for optimal infection control, use of the CDC tools on a monthly basis, self-evaluations using ICAR and audit, continuous staff education and competency evaluations, the curriculum, you can use the curriculum on an as-needed basis at this link, and continue to educate not only staff but patients. Patient education and engagement is great. So really, at the end of the day, just keep up the great work. We're really proud of what all our facilities have accomplished. We really appreciate your commitment to this project, and you striving to make to provide the best care for your patients. So thank you all. Again, this is the 8th and final. Please, please, please take that survey at the end so we can credit your facility for participation in this webinar. And reach out to us if you have any questions. But thank you all, not only for attending, but your participation in this project. All right, have a great day.